17 years ago, there was quite a lot of literature around BRCA survival and whether people who had a BRCA gene mutation were likely to survive better or worse. And the literature was incredibly conflicting. Some said it was better, some said it was worse. And it was all based on retrospective studies. So there's lots and lots of inherent biases in retrospective studies. So we set about trying to establish a prospective cohort study where we could answer this question. So that's taken 17 years to establish and to finally achieve comprehensive BRCA testing across an entire cohort of 3,000 young breast cancer patients. And we picked young breast cancer patients because they would have a higher prevalence of BRCA gene mutations. So the finding for the whole study, taking all these young breast cancer patients aged 40 and younger, firstly we found that 14% of them had BRCA gene mutations, so that's quite a high proportion. And secondly, we found that there was absolutely no difference if we adjusted for all the known prognostic factors, no difference between gene carriers and non-carriers in the whole cohort. And we were very well powered to show a difference if there was one. I think the implications are largely for patients to give them information about the prognosis. There's a common belief, I think, that people who have a BRCA gene mutation will fare worse than people who don't. So I think we can dispel that myth. It doesn't appear that that is the case at all. They do develop tumours with quite aggressive biology, but then so do a lot of other younger women. So it doesn't look like the BRCA gene mutations per se are affecting outcome if we take all breast cancer patients together. In an older age group, a much older age group, we might see more cancers arising in BRCA gene carriers that would have occurred anyway, that were nothing to do with the BRCA gene mutation in the first place, which might change the analysis slightly. But I would, given that we've adjusted for all of these factors, I think that it's likely that that result would pertain across the age groups. One of the most interesting findings was that we did a pre-planned subgroup analysis which was looking at triple-negative breast cancer patients, so patients who were young at onset again, who developed a triple-negative breast cancer and presented. All of the patients in this study presented symptomatically. And triple-negative breast cancers represented about 19% of the whole cohort. And there's a lot of interest in those patients because BRCA1 gene carriers in particular are much more likely to develop a triple-negative breast cancer than most patient groups. And what we found in that group was that there was clearly a survival advantage, particularly in the first few years from diagnosis, in favour of BRCA gene carriers, quite significant compared to the non-gene carriers. By 5 years of age, that advantage for the BRCA gene carriers had disappeared, so the hazard for relapse, the chances that somebody was going to relapse from their disease, was equal in the two groups by 5 years, but it was strikingly better in the BRCA gene carriers at about 2 or 3 years. The most likely explanation, given everything that we've been hearing about immunology and how the immune system is important for helping to eradicate cancers, particularly after chemotherapy potentially, it's quite likely that what we're seeing here is a different biological subset of the triple-negative breast cancer group. So I think the main implication is that patients who are BRCA gene carriers probably need their immune system to be working really well. We did, and it was very small numbers, but we had a little look at the patients who'd had bilateral mastectomy and reconstruction within the first year from diagnosis. Now, it was a small number of patients because not very many people were tested during that time, but about 15% of the BRCA gene carriers had had that surgery in that first year from diagnosis, and about 3% of the non-gene carriers had that surgery. And when we looked again at the survival curves, having removed the patients in case that was giving the survival advantage, what we found was that the survival advantage was even better if we took out the patients that had had bilateral breast cancers, which is slightly worrying, but it is small numbers, and one wonders whether that just might be compromising the immune response to any micro circulating tumour cells during that very early period post-treatment for breast cancer. The main message for patients is that they don't need to make a decision about radical surgery. It's not improving the outcome post triple negative breast cancer for certain. They will already have a survival advantage, and that will last for some years so that they can take their time to make any decision about risk reducing surgery, because it's not going to impact their cancer treatment. It's not part of the cancer treatment and should be considered as a separate decision.